Hey, Section 2. Nice job on Block 1, discussing medical screening, outcome measures, and pain neuroscience education. So we're just going to dive in here and do a little bit of a quick wrap up. So for medical screening, this is something that needs to happen for all patients, regardless of how they got into your clinic. Remember that it doesn't stop as soon as you decide that they're appropriate for PT or if you just start their PT plan of care. So remember that there needs to be careful monitoring along the course of their care. And remember to bring in everybody around you, mentor, assist your colleagues, and this is really where the change happens in the clinic, and you foster that environment in the clinic, and you make that place a great place to work for yourself. As far as outcome measures, this is something that by and large most of you are doing or you have plans to include. Most of you are using the LEFS or photo systems. Some people are using joint specific like hip Harris and the knee outcome, but by and large it was the LEFS, and the concepts of MCID and MCD seem to be understood. So the MCID is the important clinical change, whereas the MCD is the minimal detectable change. And so we really want that to be clinically important because we're in the clinic. And that change there is 9 points for the LEFS. That would be a great short-term goal to use, but it's not completely functional and specific to the patient sitting in front of you. So you'd want to use something that's functional that the patient has specifically come in to see you about. So I do have some MCID numbers here for you for photo. This is from Rodigero's paper in 2015, if I'm not mistaken. So the MCID is a little bit more complicated for photo, but might be good to just print that table off and cut it out for clinic. And then pain neuroscience education. So if we think, this is a bit of a busy slide because this is used for my dissertation work, but if we think about injury and then the patient's pain experience, if they go into, we have some influence here in this negative affectivity, but really in the threatening illness information. So we need to make sure that we're not using words that are going to cause some catastrophizing over their pain, thinking, oh, this is never going to go away, my pain is the worst, which leads into pain-related fear, which is another place that we can insert some influence or intervention with our pain neuroscience education in decreasing fear, in that pain doesn't mean you're doing any damage to any of your tissues. So we can avoid this whole loop on the left, or we can try to break somebody out of it. These other articles and arrows are the places in this circle that research has been done. So, and here's just an overview of the current evidence for pain science education. Not an exhaustive list, but one that I'm using to base my dissertation off of, so I figured I'd share it with you guys. So announcements. So next week we have the next block. We have discussion on the case subjective exam. Remember that's individual submission, and then you'll discuss in your groups. We're starting block 2, and so the first week is for reading and all of your materials and watching your materials. And so resident virtual rounds for ortho and sports residents and the manual therapy certification participants is going to start, and you need to see that announcement in Moodle. So you guys keep up the great work. There was a ton of back and forth discussion. I loved it. For those of you, I know that Moodle was down early in the week, so I understand that some had planned to respond then, but for block 2, hopefully we won't have those issues. And so after your post, you need to come back and check your post and the responses that you've had, that you've done to other people's posts every day, and so that you're not missing any part of the discussion that's going on there. As always, I'm open to questions anytime you may need it, and I'll see you guys back on the boards.